Hello, this is the fifth part of this placenta quintology or quintet of the DAROGA series, and now today we discuss Placenta Accreta, Increta and Percreta. We already presented part 1, the anatomy and the circulation of the placenta, physiology. Part 2 discussed variations and pathology of placenta and umbilical cord. Part 3 dealt with placenta previa, and part 4 was about placental abruption. This part deals with the morbidly adherent placenta. The placenta has grown into the myometrium or through the wall. We will have this sequence of events, definition, risk factors and incidence of placenta accreta, what are symptoms, and when is the suspicion or should the suspicion be high, what is required for the diagnosis, ultrasound scan, grayscale ultrasound scan and MRI, and what is the management of a suspected placenta accreta. And we summarize not only about the placenta accreta, but about all high-risk placental problems. This is the famous fat lady in an opera. She will play a role in this series in part 5 as well. High-risk placentas, which are challenging for the clinician and the patient, are the placenta previa, abruption and accreta, because they all can lead to intractable blood loss, which might endanger the life of the mother and or her baby. So that's why it's called high-risk placental challenges. Here you see a picture of our honorary Zen master in chief, Jimmy. And if you look very closely, he looks a little bit subdued. I just picked him up here from the animal hospital in Adelaide after he underwent surgery for a saliva gland tumor which was infected as well. But don't panic, he recovered very nicely and is alive and well at the moment. So healthcare for Jimmy as well, first-hand experience. Okay, definition. The placenta is abnormally attached to the uterine wall. And here I have a beautiful diagram. On the right-hand side we see that the placenta has grown through the decidua and is touching the myometrium, placenta accreta. Here in the fundus we see the placenta has invaded partly into the myometrium, Increta, and now the worst case scenario, the placenta has grown throughout the myometrium and is outside the serosa, or even could, for instance, invade the bladder. Increta, and this last one is called Percreta. What is the problem? The placenta will not detach from the uterus after a spontaneous delivery of the baby or after the baby was delivered with a Caesarean section, which usually means the placenta detaches in response to uterine contraction, and that is not the case here. And what is the risk? Massive postpartum hemorrhage when we desperately would try to remove the placenta, either digitally, manually, or with a curette. So that is endangers in particularly the life of the mother. What are risk factors? Well, previous uterine surgery, and the most well-known uterine surgery in obstetrics, of course, a lower segment Caesarean section. But also be aware of removal, prior removal of submucous fibroids, so especially when they protrude in the uterine cavity. If in the past a uterine septum was removed, or if intrauterine intracavity adhesions, synechia, were removed, that's also called the Asherman syndrome. And last but not least, if the lady has a history of a uterine perforation at the time of a D&C or a suction D&C and or hysteroscopy, that all increases the risk for this morbidly adherent placenta. What is the incidence of placenta accreta? Overall, it's very low. It's very extremely rare if there's in case of the absence of previous Caesarean section of uterine surgery. associated with the placenta previa, so the placenta is covering the os partly or completely, it's about 10%. And if it's a placenta previa in combination with one previous cesarean section, the rates goes up dramatically, and it's about 10 to 25%. So, when should our radar be red hot? When should the suspicion for placenta accreta be high? Well, the symptoms let us down because usually a placenta accreta is asymptomatic. So the fact that there are no symptoms could not lead to reassurance or slackness on our behalf, because the placenta accreta might be flying under our radar. So in case of a previous history of a cesarean section, your radar should be red hot when reviewing the morphology ultrasound scan and you notice an anterior lowing placenta close to or covering the internal os. So this is essential to take this on board. The Antepartum diagnosis is challenging. We have two imaging modalities, the ultrasound scan, the grayscale ultrasound scan, that can usually raise the doubt of a placenta accreta, but the sensitivity is not perfect. So when we combine it with an MRI, well, the MRI gives us also another picture, but still not perfectly sensitive. Even the combination of ultrasound scan and MRI, usually the conclusion is the suspicion will be confirmed, unless the placenta, of course, will be visible outside the uterine wall, for instance, invading the bladder, then the diagnosis is certain. I give you here an ultrasound example. A transvaginal ultrasound scan. This depicts the transvaginal probe nicely. And here on the right hand side you see the cervix, the cervical canal, and here at this point the internal os. This white grayish area here is all placenta. This here is the amniotic fluid. And look, the placenta here you can see part of the myometrium, the black area here, and this area, the placenta is actually, there is no clear interface. The uterine wall is not very well visible. Another picture of the same patient. Now, transvaginal probe, we can see the bladder here, and look, this is still discernible as uterine wall, here as well. But over there is no clear plane visible. Hence, this is quite suspicious for a placenta accreta, and we should treat her as such. The myometrium, and here the thinning of the uterus, or the loss of placental uterine interface, as we call it. Let me give you an example of an MRI of another patient where the placenta accreta was suspected via an ultrasound scan. We see here a few MRIs. We have 3 MRIs starting from caudal. This is a cross section. Here is the right hand side of the patient. This is the anterior abdominal wall, and this is her back. Look, you see the hip joints here. This is the placenta completely covering the os. So no doubt about it that this is a placenta previa, grade 4. Now we do a slice a few millimeters higher, slightly more cranial. The same picture, right and anterior are the same. Here we can see nicely the fetal skull, which looks normal, so the baby is in a cephalic presentation. And here, this gray almost looks like a boomerang. This is the placenta. And over here is an area where there is no more uterine wall visible. And this raised the suspicion on the MRI of a placenta percreta. The description of the radiologist even refers to the fact that the placenta is close to the iliac vessels. Quite scary. Another slice, the third one, we go a little bit higher, and the same here, there is no clear interface visible. By the way, it's a bit of an odd, atypical location that on the right hand side laterally, there appears to be a placenta percreta. And that must mean that in her previous caesarean section, the uterine scar, which usually is in this area, in the anterior compartment, that the uterine scar must have extended, so there must be a tear moving to the lateral side. That is my conclusion in hindsight. But anyway, this MRI raises very high suspicion for a placenta percreta, and it was confirmed during the operation. So, ultrasound and MRI, quite often the conclusion of both reports is suspicion, or placenta accreta cannot be ruled out. So here we are as clinicians. What we should do? Should we wait and see and cross our fingers? No, we should prepare for the worst case scenario. What is the management? Prepare, prepare, prepare. In case of the suspicion, we have to prepare for the worst case scenario, which means we schedule an elective caesarean section and prepare for a caesarean hysterectomy. So as soon as the baby is born, we will take out the uterus as well. We do not try to deliver the placenta. We also prepare for massive postpartum hemorrhage, which can be multiple liters. So it's essential that we have close cooperation with an anaesthetist, who will use the cell saver, the blood bank, the haematologist, the urologist, and the intervention radiologist. So what do we do in preparation? We will ask the intervention radiologist to place, with a Seldinger procedure, the internal balloon catheters in both internal iliac arteries. And that's just in case we confirm the placenta accreta after having done a laparotomy, we can inflate those balloons, and that will reduce the blood flow that stops the blood flow in internal iliac arteries and hence the uterine arteries, and that will limit the blood loss. So that's a temporary measure to minimize the blood loss. Intervention radiology is involved. This procedure in itself is invasive and in a high-tech environment. Secondly, we would like to place catheters in both ureters. So we have to do a cystoscopy and insert catheters. And usually that's done by a urologist, or if the gynecologists have the experience, we can do it ourselves. We ask the anaesthetist to stand by the decision. This procedure can be done under spinal rather than general anesthetic, but the cell saver is standby to reinfuse any red blood cells lost of her autologous blood. And of course, essential, before we start doing this operation, already as soon as we have the diagnosis and the suspicion, we should ensure solid hemoglobin and iron stores through proper nutrition and, if need be, supplementation, or even an iron in IV transfusion. Let's continue with the management. Big eyeball, because we will do a laparotomy. Elective caesarean section will take place after the stents have been placed and the ureteric catheters. We start doing the laparotomy, and then we inspect very carefully whether the placenta is morbidly adherent. Quite often it's really a visual, an eyeball diagnosis. If it's confirmed, then we will do a classical uterine incision to deliver the baby. We clamp and cut the umbilical cord, and we close the uterus and then proceed with an hysterectomy. The classical uterine incision, I will explain that in the next slide. We should not try to remove the placenta because that results in more blood loss than necessary, and we proceed with the hysterectomy. The classical incision refers to the incision in the uterus, not in the abdominal wall. So a midline laparotomy can be combined with a lower segment uterine caesarean section. This is the classical incision, where the incision in the uterus is in the vertical, in the midline, and it's going through the corpus, through the myometrium here. It's not in the lower uterine segment. Compare that with the usual procedure where this incision is in the lower uterine segment. It's the so-called horizontal incision as well. Okay, I'll show you now a specimen of a lady where we did a Caesarean hysterectomy. You can see here on the right hand side the uterus. This is the cervix. This is the corpus of the uterus. And this was the incision we made high up in the uterus. Because look here, this is the anterior uterine wall, and there was hardly any covering. There was a little bit of serosa covering the uterus, but it was almost, yeah, it was a placenta Increta. It is amazing if you look that this lady still made it to 36, 37 weeks. Here we see another specimen where it's clear this is part of the vagina, the cervix, the fundus of the uterus. The placenta is covering the internal os completely and was morbidly adherent to the anterior wall. And we see here the umbilical cord. So this is the treatment, the choice of the Placenta Accreta, Percreta, Increta. By the way, students quite often ask me, well, they have read a report, a case report, where women were given methotrexate or where the placenta was left inside you. Those are rare case reports with a good outcome. I can assure you that the bad outcomes do not end up in a medical journal. So at this stage, we have no solid evidence for conservative treatment or treatment with methotrexate. Very important, the human dimension. This is a high-risk scenario for all clinicians involved, and it's quite stressful. But on one hand, it's stressful, and on the other hand, the whole team is extremely satisfied if there's a good outcome. For the woman and her partner, we give her all the information. We discuss it, we give her leaflets. We have to discuss the different scenarios, including the possibility of a hysterectomy. And of course, we have extensive written informed consent for all these scenarios. But that means as well there's uncertainty for everybody involved. Until we have opened her abdomen, there's uncertainty whether we have to proceed with an hysterectomy or not. Whether we like it or not, this is delivery in a high-tech clinical environment. It's completely opposite from having a delivery in a bathtub and some night candlelight in the background. So there is unavoidable loss of control. That's something which we have to realize as caregivers. So continuous empathy throughout the procedure, before and after, is essential. And there's good evidence now in the literature that with a very bad outcome, the acceptance is better if we keep on giving empathy. So that's non-negotiable. Debriefing after delivery as many times as she and her partner and the family need, because it can be quite traumatic, even when there's a good outcome. Especially the partner. Sometimes the woman is not completely aware. She might be given a sedative, but especially after hysterectomy, with the loss of future fertility in a natural way, essential. If a good outcome, after a few days, maybe it's good to explore very gently her thoughts and feelings about future pregnancies. You might think intuitively, oh my goodness, not again, but women have sometimes that very interesting natural feeling, that gut feeling, they want to have another baby. And that's the fascinating part of obstetrics. But the take-home message for every antenatal care provider, whether you're a doctor or midwife, after one previous cesarean section, the morphology scan check explicitly where the placenta is located. And if low-lying and anterior, start the ball rolling. Make sure you have solid iron stores, etc. And then you can plan everything well in advance. Essential part to have a good outcome. This should not be a surprise finding at a cesarean section. So let's summarize the high-risk placenta. This was about the Placenta Accreta. Usually no symptoms, but think about this scenario after one or more cesarean sections, and the morphology scan opens the avenue to the diagnosis. We discussed ultrasound and MRI. They are not perfectly sensitive, but they quite often tell us it's most likely a Placenta Accreta or Increta. The Percreta can be diagnosed well with these imaging modalities. The treatment of choice is caesarean section, immediate followed by a hysterectomy, and you leave the placenta inside you. Comment: yes, prepare for the caesarean section and the hysterectomy and the massive PPH, and include all the other specialists to make this into a safe procedure. Don't forget about the placenta previa. The typical is painless antepartum hemorrhage, sometimes an abnormal fetal lie in the third trimester. The ultrasound scan, the grayscale, is very reliable, is quite diagnostic, and the management will be, the delivery will be caesarean section, and the timing depends on the gestational age and the absence or presence of antepartum hemorrhage and CTG changes. Prepare for massive PPH. And abruption, usually there is antepartum hemorrhage and typically with continuous pain because there is a titanic uterine contraction without relaxation of the uterus, and quite often with CTG changes. And diagnostic for a complete abruption is the sad conclusion that there is no fetal heart rate audible anymore. There are other symptoms pointing at a placenta abruption, sometimes frequent uterine contractions or the CTG. The D-dimer could be up, pointing at clot formation, and disappointingly the ultrasound is not helpful in the acute stage. Delivery, well, caesarean section, vaginal delivery depends on whether the lady had previous vaginal deliveries, depends on the CTG, etc. So there is not one clear answer. And again, prepare for massive PPH. Differentiate from preterm labor. Preterm labor can be associated with intermittent uterine contractions, which is perceived as pain, and the loss of some mucousy blood. Of course, always think about, should we administer anti-D if the lady is rhesus negative. So the placenta is indeed a fascinating organ, vital for the fetal well-being, and the placenta should not invade the uterus beyond the maternal decidua, as we saw in this 5th lecture, should not cover the internal os in the 3rd trimester, because then we're dealing with the placenta previa, and should detach completely, but only after the baby is born. Otherwise we have a partial or complete abruption. Well, if this not is the case, we should, as doctors and caregivers, be prepared for high-risk placental problems. Be prepared. Well, this concludes the quintet, or should I say quintology, of the placenta series in DAROGA, the Placenta Accreta. But hold on, it ain't over yet until the fat lady sings. Yeah, that's an appropriate expression that comes from the opera world. Here you see, of course, a lady which is quite voluptuous. We discussed 5 parts of placenta, and hold on, it ain't over until Jimmy sings. Absolutely. Hey, Jimmy had his operation, but look here, he's on the mend. He's on walkabout, and you see him here enjoying the beautiful, fascinating skyline in Adelaide close to sunset. Jimmy, he's our honorary Zen Master in Chief. And this is now really the end. Thank you. The end of this 5th lecture, but of all the 5 placental lectures. I trust it gave you some insight in this really fascinating body part, I should say, of a pregnant lady. All the best.